personality disorder. Borderline personality disorder, BPD, also known as emotionally unstable personality disorder, is a personality disorder characterized by a long-term pattern of intense and unstable interpersonal relationships, distorted sense of self, and strong emotional reactions. Those affected often engage in self-harm and other dangerous behaviors, often due to their difficulty with returning their emotional level to a healthy or normal baseline. I'm eating some black licorice. I think it's by Daryl Leah, the brand. Okay, so they may also struggle with a feeling of emptiness, fear of abandonment, and detachment from reality. Symptoms of BPD may be triggered by events considered normal to others. BPD typically begins by early adulthood and occurs across a variety of situations. Substance use disorders, depression, and eating disorders are commonly associated with BPD. Some 8 to 10% of people affected by the disorder may die by suicide. The disorder is often stigmatized in both the media and the psychiatric field, and as a result is often underdiagnosed. This licorice is so good. The causes of BPD are unclear, but seem to involve genetic, neurological, environmental, and social factors. It occurs about 5 times more often in a person who has an affected close relative. Adverse life events appear to also play a role. The underlying mechanism appears to involve the frontal limbic network of neurons. BPD is classified in the American Diagnostic and Statistical Manual of Mental Disorders, DSM, under the dramatic cluster of personality disorders, along with antisocial, histrionic, and narcissistic personality disorder. The condition and other personality disorders can be misdiagnosed as mood disorders, substance use disorders, or other disorders. BPD is typically treated with psychotherapy, such as cognitive behavioral therapy, CBT, or dialectical behavioral therapy, DBT. DBT may reduce the risk of suicide in the disorder. Therapy for bipolar disorder, borderline personality disorder, can occur one-on-one or in a group. While medications cannot cure BPD, they may be used to help with associated symptoms. Quetiapine and SSRI antidepressants remain widely prescribed for the condition, but their efficacy is unclear. A 2002 study found fluvoxamine, an SSRI, significantly improved rapid mood shifts in female borderline patients. While a more recent meta-study found the use of medications still unsupported by evidence, severe cases of the disorder may require hospital care. About 1.6% of people have BPD in a given year, with some estimates as high as 6%. Women are diagnosed about 3 times as often as men. The disorder appears to become less common among older people. Up to half of those with BPD improve over a 10-year period. Those affected typically use a high amount of healthcare resources. There is an ongoing debate about the naming of the disorder, especially the suitability of the word borderline. The term originally referred to borderline insanity and later to patients on the border between neurosis and psychosis, an interpretation of the disorder now considered outdated and clinically inaccurate. Signs and symptoms. BPD is characterized by 9 signs and symptoms. To be diagnosed, a person must be at least 5 of the following: frantic efforts to avoid real or imagined abandonment, unstable and chaotic interpersonal relationships, often characterized by alternating between extremes of idealization and devaluation, also known as splitting, markedly disturbed sense of identity and distorted self-image, impulsive or reckless behaviors. Example: impulsive or uncontrollable spending, unsafe sex, substance use disorders, reckless driving, binge eating. Recurrent suicidal ideation or self-harm, rapidly shifting intense emotional dysregulation, chronic feelings of emptiness, inappropriate intense anger that can be difficult to control, transient stress-related paranoid or severe dissociative symptoms. Overall, the most distinguishing symptoms of BPD are pervasive patterns of instability and interpersonal relationships and self-image, alternating between extremes of idealization and devaluation of others, along with varying moods and difficulty regulating strong emotional reactions. Dangerous or impulsive behavior is also characterized with the disorder. Other symptoms may include feeling unsure of one's identity, morals, and values, having paranoid thoughts when feeling stressed, depersonalization, and in moderate or to severe cases, stress-induced breaks with reality or psychotic episodes. stress disorder, and attention deficit hyperactivity disorder. Emotions. People with BPD may feel emotions with greater ease and depth, and for a longer time than others do. A core characteristic of BPD is affective instability, which generally manifests as unusually intense emotional responses to environmental triggers, with a slower return to a baseline emotional state. According to Marshall Linehan, the sensitivity, intensity, and duration with which people with BPD feel emotions have both positive and negative effects. People with BPD are often exceptionally enthusiastic, idealistic, joyful, and loving, but may feel overwhelmed by negative emotions, anxiety, depression, guilt, shame, worry, anger, etc. Experiencing intense grief instead of sadness, shame and humiliation instead of mild embarrassment, rage instead of annoyance, and panic instead of nervousness. Studies have shown that borderline patients experience chronic and significant, not insignificant, emotional suffering and mental agony. People with BPD are also especially sensitive to feelings of rejection, criticism, isolation, and perceived failure. Before learning other coping mechanisms, their efforts to manage or escape from their very negative emotions may lead to emotional isolation, self-injury, or suicidal behavior. They are often aware of the intensity of their negative emotional reactions, and since they cannot regulate them, shut them down entirely, since awareness would only cause further distress. This can be harmful, since negative emotions alert people to the presence of problematic situation and and move them to address it. While emotional dysregulation is a key feature of BPD, Fitzpatrick said that, or I think that's the source, is Fitzpatrick, argue that dysregulation itself may not be unique to BPD and be shared by other disorders, such as generalized anxiety disorder. However, their study did suggest that those with BPD may have a harder time disengaging from their negative emotions, using distraction to manage their emotions and returning to a baseline emotional state. While people with BPD feel euphoria, ephemeral or occasional intense joy, they are especially prone to dysphoria, a profound state of unease or dissatisfaction, depression, and or feelings of mental and emotional distress. Zanarini, ETIL, period, recognized 4 categories of dysphoria typical of this condition: extreme emotions, destructiveness or self-destructiveness, feeling fragmented or lacking lacking identity, and feelings of victimization. With these categories, the BPD diagnosis is strongly associated with a combination of three specific states: feeling betrayed, feeling out of control, and feeling like hurting myself. Since there is a great variety in the types of dysphoria, people with BPD experience, the amplitude of the distress is a helpful indicator. In addition to intense emotions, people with BPD experience emotional lability, changeability, or fluctuation. Although that terms suggest rapid changes between depression and elation, mood swings in people with BPD more frequently involve anxiety, with fluctuations between anger and anxiety, and between depression and anxiety. Interpersonal relationships. People with BPD can be very sensitive to the way others treat them, feeling intense joy and gratitude at perceived expressions of kindness, and express sadness or anger at perceived criticism or hurtfulness. People with BPD often engage in idealization and devaluation of others, alternating between high positive regard for people and great disappointment in them. Their feelings about others often shift from admiration or love to anger or dislike. After a disappointment, the threat of losing someone, a perceived loss of self-esteem in the eyes of someone they value. This phenomenon is sometimes called splitting. Combined with mood disturbances, idealization and devaluation can undermine relationships with family, friends, and coworkers. While strongly desiring intimacy, people with BPD tend towards insecure, avoidant, or ambivalent, or fearfully preoccupied attachment patterns in relationships, and often view the world as dangerous and malevolent. People with BPD are prone to feeling angry at members of their family and alienated from them. On their part, family members often feel angry and helpless at how their BPD family members relate to them. Parents of adults with BPD are often both over-involved and under-involved in family interactions. In romantic relationships, BPD is linked to increased levels of chronic stress and conflict, decreased satisfaction of romantic partners, domestic abuse, and unwanted pregnancy. However, these links may apply to personality disorders in general as well. According to some research, some people with BPD tend to move quickly between relationships, described in at least one case as a butterfly-like. Other individuals would instead cling closely to a few relationships, becoming reliant on fewer people than those without BPD. Behavior. Impulsive substance use disorders, e.g. alcohol use disorder, eating in excess, unprotected sex, or indiscriminate sex with multiple partners, reckless spending, and reckless driving. Impulsive behavior may also include leaving jobs or relationships, running away, and self-injury. People with BPD might do this because it gives them some feeling of immediate relief from their emotional pain, but in the long term may feel shame or guilt over consequences of this behavior. A cycle often begins in which people with BPD feel emotional pain, engage in impulsive behavior to relieve that pain, feel shame and guilt over their actions, feel emotional pain from the shame and guilt, and then experience stronger urges to engage in impulsive behavior to relieve the new pain. As time goes on, impulsive behavior may become an automatic response to emotional pain. Self-harm and suicide. Self-harming or suicidal behavior is one of the core diagnostic criteria in the DSM-5. Self-harm occurs in 50 to 80% of people with BPD. The most frequent method of self-harm is cutting. Bruising, burning, head banging, and biting are also common with BPD. People with BPD may feel emotional relief after engaging in self-harm. The estimation of lifetime risk of suicide among people with BPD varied depending on method of investigation, between 3 and 10%. There is evidence that men diagnosed with BPD are approximately twice as likely to die by suicide as women diagnosed with BPD. There is also evidence that a considerable percentage of men who die by suicide have undiagnosed BPD. The reported reasons for self-harm differ from the reasons for suicide attempts. Nearly 70% of people with BPD self-harm without trying to end their lives. Reasons for self-harm include expressing anger, self-punishment, generating normal feelings, often in response to dissociation, and distracting oneself from emotional pain or difficult circumstances. In contrast, suicide attempts typically reflect a belief that others will be better off following their suicide. Suicide and self-harm are responses to feeling negative emotions. Sexual abuse can be a particular trigger for suicidal behavior in adolescents with BPD tendencies. Sense of self. People with BPD tend to have trouble seeing their identity clearly. particular, they tend to have difficulty knowing what they value, believe, prefer, and enjoy. They are often unsure about their long-term goals for relationships and jobs. They can cause people with BPD to feel empty and lost. Self-image can also change rapidly from healthy to unhealthy. People with BPD may base their identity on others, leading to chameleon-like changes in identity. Cognitions. The often intense emotions people with BPD experience may make it difficult for them to concentrate. They may also tend to dissociate, which can be thought of as an intense form of zoning out. Others can sometimes tell when someone with BPD is dissociating because their facial or vocal expressions may become flat or expressionless, or may appear distracted and numb to emotional stimuli. Dissociation most often occurs in response to a painful event or something that triggers the memory of a painful event. It involves the mind automatically redirecting attention away from the current event or situation or blocking it out entirely. This is done presumably to protect against, based on similar or related past experiences, what the mind perceives and forecasts as arousing intense negative emotions and unwanted behavioral impulses that the present emotive event might trigger. With the mind's habit of suppressing and avoiding intensely painful emotions may provide some temporary feelings of relief. But dissociation can also lead to unhealthy coping mechanisms, while simultaneously causing the side effect of blocking out or blunting positive emotions, thereby reducing the access of people with BPD to the valuable information those emotions provide, information that helps to guide effective, healthy decision making in daily life. Psychotic symptoms. Though BPD is primarily seen as a disorder of emotional regulation, psychotic symptoms are fairly common, with an estimated 21 to 54% prevalence in clinical BPD populations. These symptoms are sometimes referred to as pseudopsychotic or psychotic-like terms that suggest a distinction from those seen in primary psychotic disorders. Recent research, however, has indicated that there is more similarity between pseudopsychotic symptoms in BPD and true psychosis than originally thought. Some researchers critique the concept of pseudopsychosis for, on top of weak construct validity, the implication that is not true or less severe, which could trivialize distress and serve as a barrier to diagnosis and treatment. Some researchers have suggested classifying these BPD symptoms as true psychosis, or even eliminating the distinction between pseudopsychosis and true psychosis altogether. The DSM-5 recognizes transient paranoia that worsens in response to stress as a symptom of BPD. Studies have documented both hallucinations and delusions in BPD patients who lack another diagnosis that would better account for these symptoms. Phenomenologically, I'm not sure how to say that, research suggests that auditory verbal hallucinations found in patients with BPD can be reliably distinguished from those seen in schizophrenia. Some researchers suggest that there may be a common etiology underlying hallucinations in BPD and those in other conditions like psychotic and affective disorders. Thank you for watching.